Welcome to the poster session of the Breath Biopsy Conference 2024. My name is Antonio Murgia and I'm a lead analytical research and development scientist working for the hepatology team at Houston Medical. Thank you for joining me today. I'm excited to present the findings of our in vitro study on unrevealing metabolic pathway in vitro study of deuterated exogenous volatile organic compounds metabolism in primary human hepatocytes. Liver disease is a significant global health concern with a range of etiologies. Often the symptoms of liver diseases appear only at later stages, making early diagnosis a challenge. Traditional diagnostic methods are often invasive, and thus there is a growing demand for non-invasive techniques to monitor liver function and diagnose disease at an early stage. In this study, we aim to explore a potential pathway for non-invasive diagnosis by investigating the metabolism of deuterated exogenous volatile organic compounds, or EVOCs, in primary human hepatocytes. EVOCs are of particular interest because the liver metabolizes them, and the metabolic bioproducts can potentially be detected in exhale breath, offering a unique diagnostic approach. For this purpose, we employed a novel platform, HiSorb extraction, coupled with the thermal desorption gas chromatography Orbitrap-MS spectrometry. This method allows us to perform precise metabolic profiling, which could have broad application in identifying metabolic changes for disease diagnosis and drug screening. For this experiment, 5 labeled EVOCs to pentanone D5, to butanone D5, limonin D5, nonanal D18, and benzyl alcohol D7 were administered to 1 million primary human hepatocytes per milliliter. The concentration of the substrate was maintained at 10 nanogram per microliter. We used HiSorb agitator at 37 degrees with 300 rpm for 2 hours to extract volatile compounds. Alongside, we established a positive control using the hepatocyte without the EVOCs and a negative control with EVOCs but not hepatocytes. Furthermore, we repeated the experiment in the presence of enzymatic inhibitors, Torrestart, an AKR1B10 inhibitor, and 4-methylpyrazole, an alcohol dehydrogenase inhibitor, to examine their effects on metabolic pathways. All samples were analyzed using TDGC Orbitrap-MS, and we performed both targeted and untargeted analysis to compare the levels of bioproducts formed across the experimental conditions. Our findings clearly demonstrated that bioproducts formation only occurred in the presence of hepatocytes, confirming that the metabolism of these EVOCs was dependent on the cells. Out of the 5 substrates, we found that 4 showed a clear conversion into bioproducts. Interestingly, nonanal D18 and benzyl alcohol D7 exhibited decreased in their level, indicating their metabolism. Among these, the metabolism of benzyl alcohol D7 into benzaldehyde D6 was particularly noteworthy, as it was significantly inhibited by 4-methylpyrazole, confirming the involvement of alcohol dehydrogenase in the process. This highlights the importance of enzymatic pathways, particularly cytochrome P450 enzymes, in the hepatocyte metabolism of these substrates. However, we did not observe significant changes with 2-butanol D5, 2-pentanone D5, and limonin. These results were also confirmed by untargeted analysis, which revealed also more potential deuterated compounds that, once identified, could be potentially used as bioproducts too. Overall, these results confirm the feasibility of using deuterated EVOCs to study liver metabolic activity in vitro, and they also open the door to the possibility of using volatile biomarker for non-invasive liver disease diagnosis. In conclusion, our study demonstrates the potential of using HiSorb extraction and TDGC-MS analysis to investigate volatile metabolic pathways in hepatocytes. This method has a significant implication for non-invasive diagnostic approaches and could be pivotal in early-stage liver disease detection by monitoring changes in breath VOCs. We also established that enzymatic inhibitors like 4-methylpyrazole can be employed to further elucidate specific metabolic pathways, particularly for benzyl alcohol. There is a much more to explore in this field. Our results encourage further investigation into how this metabolic alteration can be used to identify new biomarker and therapeutic targets. Lastly, I'd like to highlight the novel aspect of our research. We demonstrated that HiSorb extraction combined with the TDGCMS is a powerful and alternative approach to confirm enzymatic metabolic pathways, providing a cutting-edge method for analyzing VOC's metabolism. Thank you for your attention, and I hope you enjoyed my poster.
Good morning to all Breath Biopsy Conference 2024 attendances. The study I'm going to present today is based on the application of a complementary methodological approaches for the identification of a pattern of volatile organic compounds and inorganic compounds in the exhaled breath as biomarkers of lung cancer. The international scientific community has highlighted over the years that lung cancer, expressed in all its histologic types, represents the leading cause of a cancer-related death worldwide. The diagnosis of the disease generally occurs at an advanced stage. Therefore, there is an ever-increasing need to keep the national health systems with a reliable diagnostic tool, alternative to traditional diagnostic exams, addressed to a larger scale screening programs. In this regard, to explore potentialities of breath analysis in the identification of lung cancer biomarkers, a prospective observational study based on the application of complementary methodological approaches and analytical techniques was carried out. The present study is in detail the result of a protocol collaboration established between the University of Bari and University of Verona in Italy, with the support of the medical team of the lung unit at Pedersoli Hospital in Verona. Within the observational study, an overall number of 110 individuals were recruited. More specifically, 55 patients affected by lung cancer and 55 healthy controls. The enrollment of volunteers in the study fulfilled specific inclusion criteria, and the study protocol was approved by the Italian Ethical Committee. Lung cancer patients and healthy controls populations were matched by age, sex, and tobacco smoking habits as much as possible. As previously mentioned, two different methodological approaches for breath sampling and analysis were applied. For each volunteer recruited at the Pedersoli Hospital, the entitled breath was contextually sampled using two different devices. The automatic sampler named the Mistral, allowing breath collection directly onto two beds absorbing cartridges, and the BioVox sampler. Ambient air samples were simultaneously collected at each sampling session with both the sampling approaches. Samples collected with Mistral were then analyzed by thermal desorption coupled with gas chromatography mass spectrometry, TDGC-MS methodology at the University of Bari, while samples collected by BioVox sample were analyzed by ion molecular reaction mass spectrometry, IMR-MS methodology at the University of Verona. Why TDGC-MS methodology was addressed at a wide range via cis qualitative and semi-quantitative analysis, the IMR-MS methodology was a priori optimized on a selected pattern of inorganic compounds. Non-parametric statistical treatment of a TDGC-MS data by Wilcoxon Kruskal-Wallis test allowed to identify a selected VOCs pattern showing abundances in entitled breath samples of lung cancer patients significantly different from those of healthy control. More specifically, pentadecan, isoprene, 2-butoxyethanol, dimethylnonan, and a benzene derivative not uniquely identified in the present study. The application of IMR-MS methodology highlighted, in addition, the potential discriminant capability of a dimethyl sulfide and dimethyl disulfide between healthy controls and lung cancer groups. Based on the most weighting variables identified, those characterized by p-values lower than 0.05, linear discriminant analysis was applied to the dataset, providing clustering between controls and lung cancer groups. The two discriminant factions, LED1 and LED2, accounted for the 70 and 29% of the total data variance, respectively. LD1 was mainly loaded by dimethylnonan, while LD2 by isoprene, 2-butoxyethanol, the benzene derivative, and pentadecane. Finally, the predictive model developed on the selected features with a leave one out validation approach enabled to discriminate between healthy controls and lung cancer patients with a diagnostic accuracy of 99%. The discriminant variables identified in the study as biomarkers of lung cancer are in line with scientific literature. A relevant number of studies underline higher concentration of long-chain alkanes, mono and dimethyl bridge alkanes, and selected alcohols in the breath of lung cancer patients with respect to healthy controls due to improved lipid peroxidation in tumor cells. On the contrary, the role of dimethyl sulfide and dimethyl disulfide in lung cancer cell metabolism has not been elucidated yet. These compounds have been cited in previous studies in lung cancer and are worthy of future in-depth studies. In conclusion, the investigation approach applied in this study based on the simultaneous application of different analytical techniques revealed to be strategic to emphasize the chemical information in human breath and in detecting metabolites with a discriminant power between healthy controls and lung cancer patients. The outcomes of this study, moreover, stimulated debate within the international scientific community on specific compounds not yet associated to a metabolic route and can guide future research on the topic.
Hello, I'm Alexandra Matten, a lead scientist in the Breath Biopsy Test Research Program at Alston Medical, and today I'll be giving a brief overview of a recent poster presented to the American Society for Mass Spectrometry. In this work, we developed and optimized a highly sensitive method to detect and quantify deuterium-labelled volatile organic compounds using Orbitrap mass spectrometry in samples from both our preclinical and clinical work streams, showing its application from in vitro models to breath biopsy for lung cancer. At Alston, we are looking to use the EVOC strategy to test for lung cancer on breath. This strategy uses a small custom drug molecule made up of an enzyme cleavable region conjugated to a volatile organic compound, or a VOC. This custom molecule, or EVOC probe, targets a specific enzyme associated with the disease, and upon interaction with the target enzyme, the EVOC probe gets cleaved and releases the VOC. There are many enzymatic pathways which are disrupted or changed by lung cancer. The target of Alston's primary lung cancer strategy is an enzyme called beta-glucuronidase. In healthy cells, this enzyme is only found in the intracellular space, but in the tumor microenvironment, it is found extracellularly. We are targeting the extracellular beta-glucuronidase with a custom EVOC probe, which links a sugar molecule to an isotopically labeled volatile alcohol, in this case, deuterated ethanol or D5-ethanol. This probe cannot readily penetrate the cell membrane. Therefore, we hypothesize that the EVOC probe is only broken down by extracellular beta-glucuronidase, and therefore detection of D5-ethanol would be indicative of lung cancer. While the EVOC probe targeting beta-glucuronidase makes up Alston's leading strategy to detect lung cancer on breath, another strategy earlier on in the pipeline instead targets aldehyde-ketoreductase enzymes, or AKRs. AKRs are upregulated in lung cancer in response to greater lipid peroxidation, which results in higher amounts of aldehydes and ketones. These compounds are reduced by AKRs into alcohols, which are more readily cleared from the body. We're looking to administer deuterated aldehydes as EVOC probes and monitor the release of deuterated alcohols produced after reduction by AKRs, while higher amounts of deuterated alcohols would indicate greater AKR activity, suggesting lung cancer. This strategy is still in development, and Alston has used in vitro techniques to demonstrate the application preclinically, but as I'll show in the rest of this poster, we have optimized our method of thermal desorption with gas chromatography with mass spectrometry, or TD-GC-MS, to detect VOCs in preclinical and clinical breath samples. We use the TD-GC-MS method to analyze in vitro samples, in vivo samples, and patient breath samples. Our in vitro samples were collected from cell cultures, where supernatant was transferred from well plates to headspace files, and high-capacity sorptive probes, or HiSorb probes, were used to chemically extract volatiles from the headspace of the samples. In these experiments, A549 and H460 lung cancer cell lines were treated with different AKR inhibitors before aldehyde EVOC probes were administered to the wells. Subsequently, we analyzed the headspace samples for aldehyde and alcohol bioproduct levels. The in vivo samples were collected from mice, where mouse breath was collected onto sorbent tubes through a chamber pumped with clean air. We demonstrated recovery of known amounts of VOCs in water droplets in the chamber before the animal studies, and then collected breath samples from the mice treated with positive control amounts of target VOC, and from mice with and without tumors treated with different concentrations of Alstone's EVOC probe targeting beta-glucuronidase. And in our clinical study for lung cancer, healthy volunteers and patients with different stages of lung cancer have breath samples collected before and after administration of the EVOC probe targeting beta-glucuronidase. The analytical workflow is applicable to samples from preclinical to clinical breath studies. HiSorb probes that captured volatile compounds from the headspace of in vitro samples were thermally desorbed in the same way as sorbent tubes containing mouse breath or patient breath samples. Under clean gas flow, the HiSorb probes or sorbent tubes were heated such that volatile compounds are lifted from the sorptive materials and sent to a focusing trap, where the compounds are pre-concentrated while solvents such as air or water vapor can be removed with minimal loss of target compounds. The focusing trap is then heated to dissolve the volatile compounds to send the gas chromatography column for separation. A Q-exactive Orbitrap-MS spectrometer in electron ionization mode was used to detect targets in single ion monitoring scans. The analytical method was optimized for sensitivity for the targets in the sample matrices while minimizing sample runtime. The first choice of deuterium-labelled VOCs over natural compounds gave background resolution such that small concentrations of EVOC probes could be administered and a unique VOC product could be detected. Single ion monitoring scan increased sensitivity for the selected quantifying ions for each compound. The GC ramp was optimized to improve resolution between target compounds and interfering ions found in the breath matrix. And the dilution factor when the cold trap is thermally dissolved to the GC column was optimized to minimize background effects from human or mouse breath. The results for the in vitro studies showed that as AKR inhibitors were administered to the A549 and H460 cell lines, the enzymatic reduction of aldehyde to alcohol was diminished. While the washout on the administered aldehydes over time could not distinguish between different levels of AKR activity, the fold changes in alcohol bioproduction clearly indicated lower AKR activity associated with the inhibitor treatments. We saw from the in vivo result that breath collected from mice treated with increasing doses of the target VOC, there was a correlation between the dose and the response. However, there was variation between animal to animal. At this stage, the detection of target VOC in mouse breath following administration of the EVOC probe was inconclusive, with animal-to-animal variation proving greater than the D5-ethanol response detected. And the results indicated that the EVOC probe dose requires optimization, and the time points of breath collection after administration can be optimized. These are lessons learned to improve future preclinical and in vivo studies, as well as ongoing human clinical trials. The analysis of patient breath samples showed detection of D5-ethanol above the quantification limit, where we can detect D5-ethanol on breath down to 12 parts per quadrillion. Dosage still requires optimization, and more recent results after improvements to background volatile exclusion during sampling have been collected and are currently being analyzed. So while there is ongoing improvement to the preclinical and clinical study collection strategies for lung cancer detection on breath, we have shown that the method to analyze samples throughout the workstream is robust to low concentrations and large variety in sample matrix. And so to round up, the in vitro experiments demonstrated that aldehydes have potential as EVOC probes to monitor AKR activity as an indicator of lung cancer. Our new in vivo sampling platform can be used to collect small animal breath onto sorbent tubes for VOC analysis in the same workflow as clinical breath samples. And analysis of clinical breath samples using the optimized TD-GC-MS method showed parts per quadrillion levels of target VOC D5-ethanol were detectable on breath after administration of the leading EVOC strategy probe to detect lung cancer on breath. Thank you for your attention, and do reach out if you have any follow-up questions.
Hello, my name is Thibaut Massenet and I'm a PhD student at the University of Liège in Belgium, and today I'm presenting you our research on systemic sclerosis with that question: can Breathomics monitor interstitial lung disease? Systemic sclerosis, SSC, is an autoimmune disease of unknown origin characterized by an inflammatory process associated with vascular damages and collagen deposition. One of the most serious complications of SSC is interstitial lung disease, ILD, which is highly prevalent in SSC patients and is the leading cause of death in this population. The treatment of SSC-ILD requires aggressive multimodal therapies. So given this context, there is a major clinical need to identify SSC-ILD at the earliest stage using non-invasive techniques, especially for patients at risk of developing a progressive form of disease. Currently, there are only few biomarkers available to classify patients at risk of developing SSC-ILD. In previous research, we demonstrated that SSC patients exhibit a specific signature of volatile organic compounds, or VOCs, compared to healthy patients. In this prospective study, our aim was to identify the potential of VOCs to predict the ILD phenotype in SSC patients and help to better understand the metabolic pathways involved. A total of 42 patients, 21 SSC and 21 SSC, were recruited from two centers, the University Hospital of Liège in Belgium and the Maastricht University Medical Center in the Netherlands. As you can see in the right part of the lungs on the poster, the green part, we compared the exhaled breath composition between SSC and SSC-ILD patients using toddler bags. These samples were then processed to concentrate the VOCs using TD tubes, which are stainless tubes filled with solvent materials, allowing VOCs trapping. The VOCs were subsequently released and analyzed using two-dimensional gas chromatography coupled with high resolution time-of-flight mass spectrometry, GC-GC-HR-TOF-MS, a gold standard method which allows, thanks to the combination of two GC columns, to comprehensively analyze the complex matrix that is exhaled breath here. On the other hand, on the left part, the red part of the lungs, represented on the poster, we can see the example of chromatograms obtained by our analytical method where each color dot corresponds to one compound identified in patient's breath. Finally, we developed a statistical model based on partial least square discriminant analysis, PLSDA, to identify 9 significant markers based on their variable importance scores. This model achieved an area under the curve AUC of 0.82, an accuracy of 85%, a sensitivity of 77%, and a specificity of 100% in identifying the ILD phenotype. These matrices were similar to the DLCO-based univariate model, as you can see, which had an AUC of 0.83. If we have a closer look at those markers, 4 of them were consistent with our previous study, confirming their potential as biomarkers. Moreover, the VOCs-based model showed a strong correlation with clinical parameters such as TLCO. Additionally, this research also contributes to a better understanding of the disease and its associated metabolic pathways. I warmly encourage you to scan the QR code on the top right corner if you want more information about that. In conclusion, the accurate and sensitive statistical model we presented here demonstrates the potential of VOCs in exhaled breath to identify SSC-ILD patients based on their exhaled breath within a SSC cohort. Additionally, our study corroborates the potential of 4 therapies in distinguishing SSC patients. Exhaled breath analysis could help clinicians quickly provide targeted treatment to patients suffering from ILD. However, further validation of these findings in a larger cohort is necessary. Future studies should include SSC-ILD patients at early stages to evaluate longitudinal changes in VOCs compared to disease progression and treatment response. With that, I just want to thank you, and I will be happy to answer your question.
Hello, my name is Giuseppe Fernandino. I am lead scientist on the hepatology program at Boston Medical, And today I'm going to talk about this poster titled Targeted Breath Biopsy Profiling of Induced Biomarkers, Unveil a Metabolic Adaptation in Cirrhosis Toward Alcohol Production. So, chronic liver diseases can be detected by alterations of the metabolic function in the liver. And so to assess these metabolic functions, we can use compounds that are safe for human consumption. So they are metabolized in the liver and exhaled in the breath. Two of these compounds are 2-butanol and 2-pentanol, which can be ingested through the diet, and they are metabolized in the liver by the alcohol dehydrogenase pathway. And this pathway has been reported to be altered in subjects with cirrhosis. So now to assess if these compounds are actually metabolized in the liver and may differentiate between healthy subjects and subjects with cirrhosis, we conducted in vitro and in vivo experiments. For the in vitro part, we incubated these compounds with human suspension hepatocytes and assessed the appearance of the bioproducts over time. For the human experiments, we conducted a study in Chile where we administered the investigated compounds and collected the breath before and at different time points after administration. So in the results section, we can appreciate that incubation of the substrates with the human hepatocytes show production of the bioproduct only if the hepatocytes are present. Indeed, in the control conditions where hepatocytes were omitted or where the substrates were omitted, we can see that bioproducts were absent or very low, indicating that these compounds are actually metabolized in the liver and therefore they could be used to assess liver function. Now, moving on to the results from the human studies, we can see that 2-butanol and 2-pentanol were administered, and then we measured these compounds in the breath. So we can see that 2-butanol, the alcohol, is increased in subjects with cirrhosis, shown in blue, and was lower in controls, showed in gray. However, the corresponding ketone to butanol showed small differences. About to pentanol, which was administered, we can see that the bioproduct, so the alcohol 2-pentanol, showed higher differences with higher levels in subjects with cirrhosis compared to controls. Now, we can calculate the ratio of the substrates and the bioproducts, and we can see here that so this ratio allows a differentiation between subjects with cirrhosis and controls. And if we build ROC plots based on these parameters, we can see that at baseline, we measured a poor differentiation because the levels were quite similar between cirrhosis and controls, given that so the levels were very low. However, for example, already 10 minutes and 20 minutes post-administration, the classification performance of these compounds that were induced in breath by administration showed an AUC of 0.85 and an AUC of 0.86 at 20 minutes. 20 minutes showing a specificity of 0.87 and a sensitivity of 0.79. Of course, these are just exploratory rock plot, and we need to expand these findings in further studies. However, these results show that there may be a metabolic adaptation in cirrhosis that induces production of alcohol independently if we administer an alcohol or the corresponding ketone. And basically, so this adaptation may explain the findings that subjects with the chronic liver disease show higher level of circulating ethanol, which is an alcohol, in the blood, even though they have not been drinking. And this may be generated by a reduced clearance or even a higher production or maybe some production in the liver. And additionally, we also find that these metabolic alterations that take place in subjects with cirrhosis can be used to classify and identify subjects with the disease by using a non-invasive breath test. Thank you very much for your attention, and please catch up if you have any question about these results.
Hello, everyone. I'm Alessia Di Giglio from University of Bari, and it's a pleasure for me to present at the Breath Biopsy conference my poster entitled Breath Analysis, Identification of Potential Volatile Biomarker for Non-Invasive Diagnosis of Chronic Kidney Disease, CKD. Impaired kidney function is one of the major public health problems worldwide. In fact, about 13% of the total population is globally affected by chronic kidney disease, which is a persistent and progressive impairment of kidney function. Recently, volatile organic compound determination in exhaled breath has seen growing interest due to its promising potential in early diagnosis of several pathological conditions, including chronic kidney disease. Therefore, the aim of this study is to explore the role of breath analysis in the early diagnosis of CKD and non-invasive monitoring of CKD and hemodialysis patients in therapeutic follow-up. So, a cross-section observational study approved by the local ethical committee was carried out, and a total number of 13 subjects matched for age and gender were enrolled. More specifically, the breath samples were collected from 10 patients with end-stage kidney disease on chronic hemodialysis before undergoing hemodialysis treatment, referred as DIAL. 10 patients with a mild moderate CKD, referred as G, including 3 patients in stage G2 with mild albuminuria and 7 patients in stage G3, and then 10 healthy control. For each volunteer, an end-tidal exhaled breath samples and an ambient air sample were collected at the same time on 2 sorbent tubes by an automated sampling system and analyzed by thermal desorption, gas chromatography, mass spectrometry. So, non-parametric tests as Wilcoxon and Kruskal-Wallis tests allowed us to identify the most weighting variable, able to discriminate among dial, G, and control breath samples, excluding the variable related to ambient air. As shown in the table 2, only 15 VOCs showed abundance in breath samples collected from dial patients significantly different compared to those detected in control breath samples. And only 3 VOCs showed abundance value in breath samples collected from CKD subject G, significantly different with respect to those detected in breath sample collected from healthy subject. More specifically, levels of ketones, aldehydes, and aromatic hydrocarbons, such as benzene and ethylbenzene, in the breath of CKD patients were found significantly higher than the level detected in ambient air and in healthy subjects. It's probably due to the accumulation of these VOCs in human organisms, and in particular in urine of CKD patients, and due to an impaired equilibrium between peroxidative activity determined by free radicals and antioxidative mechanisms that is a typical condition of CKD patients. Considering VOCs characterized by p-value lower than 0.001 0.05. Multivariate analysis of normalized data was carried out by a linear discriminant analysis, and two different discriminant functions were computed, accounting for 89% and 10% of the total variance of the data, respectively. As shown by the score plot in Figure 2, LDA is able to discriminate between the three classes of subject, dial, G, and control. And thus, in order to validate and optimize the model, the original dataset was randomly divided in two subsets. The training set consisting of 70% of the data, and the test set consisting of 13%. Through an iterative process, the model was training starting from the training set for which the classification of the sample was no, and was validated by blinded samples with the test set. The cross-validation allowed us to evaluate the accuracies of the classification, showing an overall prediction ability equal to 89%, with only two control incorrectly classified as G, false positive. So, using the predicted outcomes, receiver operating characteristics curve were constructed for the discrimination both between G and control and between dial and control. As shown in Figure 3, ROC analysis reported promising results, showing diagnosis accuracies of 87% and 100% respectively. So, thanks a lot for your attention, and if you could find more specific information regarding this study on Molecular Journal, where it has been recently published.
Hello everyone, I'm pleased to talk to you about this presentation on an innovative approach of screening endometrial cancer. We know that endometrial cancer is the most common gynecological cancer in Western countries, and that the rise in obesity, diabetes, and hypertension has significantly increased the incidence of this cancer. Unfortunately, the number of deaths has also been on the rise. So, our research presented on this poster focuses on a non-invasive screening method using volatile organic compounds in exhaled breath, air. And by analyzing these Vocs, we could establish a respiratory profile and potentially diagnose endometrial cancer earlier than current methods. So, the need for early detection is crucial. And though the overall 5-year survival rate stands at 83%, survival rates vary greatly depending on the cancer stage. If diagnosed early, localized cases have a survival rate up to 95%, and this is our goal, is to save people earlier. And in our study, we developed a breath analysis technique to detect these Vocs, complementing traditional diagnostic tools. Initial results show that our method is very promising. With a sensitivity around 95% and specificity at 85%, our accuracy rate is an outstanding 89%. And if we can validate these results, this could become a game changer in early cancer detection. So, in the images in the results section of the document, we can see that in the image A, we have the receiver operating characteristic curve, which evaluates the diagnostic ability of the screening method. The area under the curve is 89.7%, indicating a high accuracy in distinguishing between patients with endometrial cancer and those without. On image B, this matrix represents how well the screening method classified patients. So it shows that there were some misclassifications, but overall accuracy was high, with most values correctly placed. On the table in image C, we have a table that shows us all the statistical values. So in addition of those I told you before, we have the negative predictive value at 96% and the most outstanding result is the positive predicted value at 81%. These results indicate that the method performs very well in correctly identifying both positive and negative cases. On the data section, we have a peaks comparison, and we can see that in the patients group, images A and B, there are more pronounced peaks with different intensities when compared to the control group on image C and D. And this suggests that exists a distinct metabolic profile in patients with endometrial cancer when comparing with the control group. In conclusion, we know that further studies are needed to validate these results, and we need to enroll more patients to validate this method. But with the results I just show you, we are very optimistic of this method, and we hope that we can offer people a non-invasive and reliable screening tool for screening endometrial cancer. Thank you for watching this presentation, and if you have any doubt, you can email me, and I'm looking forward to share more advances on this study with everyone in the future. So thank you and have a nice day.
My name is Marirosa Rosarianisi. I am a PhD student at the Environmental Sustainability Laboratory in the Department of Biosciences, Biotechnology and Environment of the University of Bari. Malignant pleural mesothelioma is still a poor prognosis neoplasm, mainly caused by previous asbestos exposure, occupational or environmental, and this study aimed to explore the potential of breath analysis to detecting metabolic alteration in participants with NPM and in the surveillance of subjects at risk due to the previous asbestos exposure. The management of NPM is challenging due to the long latency period between the exposure and the usually late diagnosis at advanced stage. Now, the meted 24 patients affected by NPM, 24 healthy controls, 10 former asbestos-exposed individuals, and 2 patients in follow-up after first-line chemotherapy were recruited. The methodological approach was based on the sampling of end-tidal breath directly onto 2 beds adsorbent cartridge by means of an automated sampler. Ambient air samples were simultaneously collected at each sampling session. Breath samples were thermally dissolved and analyzed by gas chromatography coupled to mass spectrometry. Non-parametric statistical treatment (OTD-CCMS) data allowed to identify a selected VOC pathogens of 84 compounds identified, showing amounts in end-tidal breath sample of patients with NPM significantly different from those in end-tidal breath sample of healthy controls. The patterns of VOCs for which a statistically significant difference was found between the sample population of patients with NPM and healthy controls includes various aldehyde compounds. To identify the feature variable with the best discrimination between groups, a multivariate analysis or normalized data was carried out by LDA, and 2 different discriminant functions were computed accounting 89% and 10% of the total variance of data. Leave one out cross-validation method was applied to calculate the prediction accuracy, obtaining sensitivity equal to 92% and diagnostic accuracy equal to 90%. In order to explore the potentiality of the development model in detection of metabolic alteration linked to previous asbestos exposure, a more extensive dataset, including exposed participants, has been processed. 2 discriminant functions, LD1 and LD2, explain 99% of the total variance of the data, and leave one out cross-validation resulted in 4 out of 10 exposed subjects misclassified as NPM. Hence, it could be proposable a further and more frequent clinical surveillance for the follow-up of these subjects. Furthermore, 2 breath samples collected from NPM patients in follow-up after first-line chemotherapy were exploratively analyzed, processed by the validated statistical method as blinded sample, and classified as NPA. Good agreement was found with patients' outcome because the two NPA follow-up subjects were in disease progression. For conclusion, the combination of non-parametric tests with the supervised classification method enabled to detect metabolites in human breath with discriminant power between healthy subjects and NPM patients. Despite the promising results, their size and the homogeneity of the sample population deserve further investigation to validate breath analysis as a helpful tool in the screening and clinical management of NPM, as well as to possibly integrate this procedure into future screening programs for at-risk previously asbestos-exposed population. Thank you for your attention.
Hello, my name is Fred Faradan, and I would like to present my poster, Strategy for Enabling Clinical Confidence in Breath Analysis. I work for the National Physical Laboratory. We are a world-leading centre of excellence that provides cutting-edge measurement science, engineering and technology that underpin prosperity and quality of life in the UK. We use our expertise to help make a difference to some of the biggest challenges in industry, energy, environment and healthcare. We are working to shape the future of healthcare to get new and more effective diagnostic tools, treatments, and medical technologies to patients more quickly. Breath analysis is a novel, non-invasive diagnostic tool that has the potential to revolutionize the early detection of diseases, the monitoring of disease progression, and personalized medicine, both in and out of the clinical environment. This will improve patient outcomes whilst also reducing healthcare costs. However, poor data comparability is inhibiting this important innovation from realizing its full potential. Our mission is to repurpose our expertise for the breath analysis community, improving data comparability and data confidence, thereby accelerating its uptake into routine clinical practice. By creating bespoke volatile organic compound reference materials to bring traceability and accuracy to quantification, driving the development of international standards, and coordinating interlaboratory comparisons, such as proficiency testing schemes, so that adherence to these standards can be demonstrated, we will be able to address the data comparability problems that the breath analysis community is facing, enabling it to realize its full potential. We have recently completed a project funded by the Government Office of Technology Transfer entitled Strategy for Enabling Clinical Confidence in Breath Analysis. From this project, we have established where our expertise could have the most impact in improving data comparability and data confidence, and have developed an implementation strategy to drive these developments forwards. The need for early diagnostic tools can be demonstrated by investigating a colorectal cancer case study. As you can see from the graph on the left, the chance of survival more than doubles from 44% to 98% when the cancer is diagnosed at stage 1 compared to stage 4. The graph on the right shows the total cost of treatment per patient over a 9-year period is 39% cheaper when the cancer is diagnosed in the earlier stages. Therefore, early diagnostic tools not only improve patient outcomes, but also save costs. In addition, having better quantitative diagnostic tools allowing for more accurate diagnoses will improve patient stratification in the NHS, thereby optimizing clinical resources. These two graphs show that the amount of peer-reviewed publications and clinical trials have grown by an order of magnitude over the past 2 decades. However, the uptake of breath analysis technology into clinical practice has not followed the same trend. Data comparability is a large contributing factor to this. If you were able to combine data from each individual clinical trial, you would massively increase the cohorts, accelerating the research and making the findings more significant. NPL have developed an implementation strategy to address the lack of data comparability and data confidence in the breath analysis community. The first step is to engage with clinicians and regulatory bodies to set up advisory groups and stakeholder communities and lead the drafting of regulations and standards for breath analysis technology. We will then look to repurpose our expertise in gas metrology and standardization to fit the needs of the breath analysis community. This will involve making new breath-specific reference materials, establishing new international standards, and running interlaboratory comparisons such as proficiency testing schemes. When successful, an improvement in data comparability and data confidence will be achieved, increasing clinical confidence in breath analysis and enabling this wondrous technology for realizing its full potential. We have applied for further funding from the GOTT to begin implementing this plan and are actively looking for collaborators who will be willing to join the stakeholder advisory group we are establishing called Respiromics SAG. Respiromics SAG's remit will be providing critical advice, information of industrial and clinical trends, and advocacy. If you are interested in helping breath analysis reach its full potential and making the difficult transition from research into routine clinical practice, please don't hesitate to get in touch. I have been Fred Faradon. Thank you for listening.
Hello, I'm Lucy Gale. I'm a Senior Research Dietitian and Clinical Project Manager at Royal Papworth Hospital and at the University of Cambridge. And along with Professor Floto, we're absolutely delighted to have worked with Alstone on this study. And thank you for inviting me to talk about it. Cystic fibrosis is a life-limiting inherited condition that causes a buildup of thick, sticky mucus in the lungs and also in other organs, and this leads to severe and persistent bacterial infections. CF is characterised by periods of relative stability, punctuated by abrupt clinical deteriorations, and these are known as acute pulmonary exacerbations or APEs. APEs drive pulmonary inflammation, cause progressive lung damage and premature death. There's a huge impact on patients' quality of life from repeated APEs, and this is due to treatment burden from IV antibiotics and hospital attendance, the unpredictability of when the APEs will occur, and the impact on work and personal life. The diagnosis of APEs and response to treatment remains very challenging, and this is due to the currently available tests that are insensitive and the reliance of subjective symptom reporting from patients. Detecting APE changes versus normal day-to-day variation in symptoms remains an ongoing challenge for clinicians. And due to these reasons, there is need for a quick and reliable bedside test for both the diagnosis of APE and the monitoring of treatment response. VOCs in exhaled breath have demonstrated great potential as a non-invasive tool for disease diagnosis and monitoring. The metabolic changes captured in breath could provide early signals for APE, as opposed to lung function measurements in which changes occur later in the development of an exacerbation. The aim of this pilot study was to see how well patients tolerated the breath biopsy, to see if there was potential for the breath biopsy to be used as a diagnostic tool for APE, and for the monitoring of IV treatment response. This study utilised the breath biopsy technology, and breath biopsies were taken at the start, middle and end of IV antibiotic treatment for APE and upon return to follow-up or baseline. This was performed in 5 adult CF patients who were attending Royal Papworth Cystic Fibrosis Specialist Centre in Cambridge. IV antibiotic treatment was either given as an inpatient or an outpatient. The breath biopsy was generally well tolerated by patients, and following collection, the VOC samples were sent to Alstone for analysis. A longitudinal profiling of the exhaled breath VOCs was performed shortly after the onset of an APE through to the resolution and back to a stable baseline. The VOCs identified may suggest the involvement or influence of inflammation, of bacterial infection, and the impact of antibiotics on the gut microbiome. The longitudinal analysis with post-hoc pairwise comparison suggests that breath VOCs have the potential to discriminate CF exacerbation from baseline, as well as antibiotic treatment response. We very much look forward to doing further work with Alstone to perform a study in a larger cohort of patients who have CF in order to validate these findings. Many thanks for your time.
Thank you for watching the presentation. My name is Bato Hammarström. This study has recently been published in Journal of Breath Research. I will be telling you about a study conducted at Environmental and Occupational Medicine, Oslo University Hospital, in collaboration with Alstone Medical. As you can see in the top left corner of the poster, occupational asthma can be allergic or irritant-induced. Irritant-induced asthma is further classified as either definite, possible, or probable, depending on the degree of irritant exposure and latency of asthma onset. The aim of the study was to identify potential exhaled breath volatile organic compounds, hereafter called VOCs, that can differentiate occupational asthma from healthy controls, as well as differentiate between irritant-induced asthma subgroups. This was a single-center cross-sectional study of 40 patients with asthma and a control group of 45 respiratory healthy healthcare workers as outlined in Figure 1. 36 of the asthma cases were evaluated to have irritant-induced asthma. Of these 36, 13 were defined as possible irritant-induced asthma, described as delayed development of asthma after repeated irritant exposure of low to moderate degree. 22 were defined as probable irritant-induced asthma, described as delayed development of asthma following multiple moderate to high-level irritant exposure. And 1 was defined as definite irritant-induced asthma, described as rapid onset of asthma after a single very high irritant exposure. The methods included collecting breath samples using the breath biopsy collection station with Receiva breath sampler and the Casper portable air supply, and analyzed with GYNE-VOX through an untargeted approach. The demographics showed that storage time, BMI, and sex were significantly different between occupational asthma and control, and this was adjusted for in linear regression analysis. 536 distinct VOCs were identified. Principal component analysis showed no differences between the groups. 76 VOCs exhibited significant differences, illustrated as orange dots on the volcano plot as shown in Figure 2. 14 of these was classified as Tier 1. While all 76 VOCs yielded a high receiver operated characteristics OSC performance of 0.94, this rate decreased to moderate 0.78 for the top 10 significant Tier 1 VOCs. As shown in the box plot in Figure 3, significant differences in VOC profiles were found between occupational asthma and healthy controls, particularly for compounds such as 1-hexadecanol, 2,3-butanediol, phenol, and xylene. These VOCs are linked to biological pathways involving reduced nicotinamide adenine dinucleotide and the production of reactive oxygen species, which in turn are associated with airway inflammation and asthma development, as illustrated in Figure 4. Also shown in Figure 3, acetone and isopropyl alcohol were increased among the controls, and they could potentially be occupational exposures among healthcare workers. Figure 5 illustrates Tier 1 VOCs that exhibit significance in occupational exposure groups compared to healthy control. Specifically, 1-hexadecanol showed associations with exposures of low molecular weight chemicals, acid or alkali, and chemical gas, smoke, and vapor. Acetone was associated with acid and alkali exposure, although this was a small group. We conclude that this study provides preliminary evidence that exhaled breath VOCs may serve as biomarkers for occupational asthma and its subtypes, with particular promise in regard to associations to NADH, ROS generation, and inflammation. Further research is required to validate these biomarkers and their potential role in clinical practice, which could enhance diagnostic accuracy and optimize treatment strategies for patients with occupational asthma. Thank you very much for listening.
Hello everyone, my name is Pasawat Bunyasit. Today I'm going to present to you a research proposal. The title is Application of Carbon-13 Metaset in Breath Test in Longitudinal Monitoring of Metabolic Dysfunction-Associated Fatty Liver Disease, Progression in Children, Adolescents, and Young Adults with History of Childhood Obesity. For the background of this study, Metabolic Dysfunction-Associated Fatty Liver Disease, or MAFLD, represents an increasingly recognized spectrum of liver pathology associated with obesity, insulin resistance, and metabolic syndrome in pediatric and adolescent populations. In children and young adults, the progression of MAFLD can lead to chronic liver disease and elevated risk of hepatocellular carcinoma, or HCC. Current tools for assessing disease progression and liver function have limitations in sensitivity and specificity. Liver biopsy remains the gold standard for diagnosing NASH and staging fibrosis. However, its invasive nature carries potential risks, making it not feasible for frequent monitoring in children and adolescents. The carbon-13 metaset in breath test, or the CMBT for short, a non-invasive test that measures the liver function through exhaled breath after the administration of carbon-13-labeled metasetin, may offer a promising solution. CMBT reflects metabolic capacity of cytochrome P450 1A2, potentially indicating subtle impairments in liver function before clinical symptoms manifest. This study aims to investigate the role of CMBT in detecting functional liver impairments across the spectrum of MAFLD, to examine the potential of CMBT in monitoring changes in liver function that may indicate progression of the disease, and to assess the correlation between the CMBT and the already established clinical biomarkers, and to develop a predictive models for risk stratification. For the proposed methodology, this study will be a longitudinal cohort study over a 5-year period. Participants include children, adolescents, and young adults ages from 8 to 25 years who has been diagnosed with MAFLD. Patient will first undergo anthropometric measurements, biochemical tests, imaging assessments of fat content and fibrosis, and histological assessment for those who have the indication for liver biopsy. There will be genetic panel screening. Variation of the genes that are known to be linked to increased risk of chronic liver diseases will be screened to identify the high-risk individuals. For the CMBT itself, firstly, we will measure the patient breath to determine the baseline of the carbon-13 and carbon-12 ratio. Then, the carbon-13 labeled metasetin will be administered. The substrate will be metabolized by the cytochrome P450, as mentioned before, which will result in the end product of the carbon-13 labeled formaldehyde. And lastly, the carbon-13 molecule will be exhaled to the base, and it will be measured again. In this study, we will try to measure the carbon-13 recovery levels at different time intervals, including 10, 20, 30, and 60 minutes. We also suggest cutoff levels for the carbon-13 recovery within 60 minutes for each stages of CLD. For NAFL, there is fat accumulation, but there is no significant inflammation or fibrosis. So we think a cutoff of 5 to 10% recovery should be expected. For NASH, there is early fibrosis and inflammation, and slight decrease in hepatic function. So we expect a value of 3 to 5% recovery. For compensated cirrhosis, there is substantial fibrosis and structural changes, but the function still maintained at a level that enables symptom management. So we think a level of 1 to 3% can be expected. For decompensated cirrhosis and HCC, there is major structural and functional hepatic loss, and sometimes they can be accompanied by end-stage liver disease. So we expect a level of less than 1% recovery as the cutoff. For follow-up, we will do it every 6 months. Participants will undergo repeated CMBT, liver function tests, and imaging. The progression to more advanced stages will be defined based on a combination of clinical parameters, imaging findings, and biochemical markers. The primary outcome of this study is the association between changes in CMBT parameters and progressions in liver disease stages as determined by clinical and imaging criteria. Secondary outcomes of the study include correlation between the CMBT values and standard biomarkers of liver function, and also the predictive values of CMBT for identifying patients at risk for decompensation or HCC development. We will use longitudinal mixed effects model to assess changes in CMBT parameters over time and evaluate their association with disease progression. The ROC analysis will be employed to determine the sensitivity and specificity of the CMBT. Survival analysis technique will also be applied to assess the utility of the CMBT in predicting time to decompensation or HCC development. Lastly, we hope that this study may establish the CMBT as a practical and sensitive tool for routine monitoring of MAFLD progression. Clinicians could be able to detect functional impairments that signify disease progression, potentially leading to timely interventions. The need for invasive dual biopsy may also be reduced, allowing for better individualized management of MAFLD in young patients.